Консилиума. Рада видеть всех вас на нашем очередном вебинаре. Несмотря на то, что с прошлого вебинара прошло не так много времени, но у нас уже есть чем новым с вами поделиться. Сегодня мы в очередной раз будем говорить о ведении туберкулеза, в этот раз в том числе и среди новорожденных, детей и подростков. Мы затронем тему,
among newborns, children and adolescents. We'll be talking about new treatment regimens, including short treatment regimens that could be used in treatment of children. Just a couple of announcements for you. As always, we offer our webinar in two languages, in English and in Russian. You can choose the language that you prefer. In the chat, you will see the instructions on how to do it. And I would like to take just a little bit of time in order to remind you that in addition to our webinars, we offer an opportunity to share expert clinical consultations. And so if you have any questions about management of TB or TB infection, you can always write to us, and you can see the email address at the screen right now. All materials of our webinars, including those that we had in the past, could be found following the link at the bottom of the slide. This is a new platform where we generated the materials of all 29 webinars that we had with you. Without any further ado, I would like to give the floor to Dr. Askar Едильбаев, the Regional Advisor on Drug-Resistant Tuberculosis at the WHO Euro. Thank you very much, Elmira. Dear colleagues, dear friends, I would like to welcome all of you on behalf of the WHO Euro at the 29th webinar of the Virtual Medical Consortium. Indeed, the work of the Virtual Medical Consortium in the European region is very important, and we are glad to see that the number of cases goes down, and the questions you ask are being successfully answered, and I hope that these answers help you in your practice. We will continue the discussion of all relevant issues during the webinar, and we have a sufficient amount of materials for the future webinars. So I welcome all of you at the present webinar, where we'll talk about the diagnosis and treatment of tuberculosis in children and adolescents. And I would like to thank all the speakers who have joined us today for this webinar. Once again, thank you very much, and I give the floor to Elmira. Thank you, Askar. And now I would like to give the floor to the first speaker, our dear Dr. Sabine from the WHO headquarters, who will tell us about the 4-month treatment regimen of drug-susceptible tuberculosis and about the introduction of this WHO-recommended treatment regimen in the world. Sabine, please, the floor is yours.
Thank you very much, colleagues. Thank you very much, Elmira and Askar. I hope you can see already my screen. I'll just try and put it in full screen mode. If you can just confirm that you can see it.
Yes, we see it.
Yes. Okay, excellent. So thanks very much for the invitation. So my name is Sабине Веркуй. I'm working at the Global TB program as a medical officer, mainly focusing on child and adolescent TB. And I'm here with my colleague, team lead, Kerri Wайni. And I think our other colleague, Annemieke Brons, is also on the line. So we are a team that works on child and adolescent TB as part of the unit that is called People-Centered Services, Communities and Determinants. I'll take you through the 4-month regimen, the regimen for the treatment of non-severe TB in children and adolescents today. And just to start, to indicate that the WHO policy guidance on TB in children and adolescents really covers the entire cascade of care. And this slide shows the cascade of care from susceptibility and exposure all the way to diagnosis and treatment on the top, as well as preventive treatment on the bottom. And then at the bottom of the slide, you can see the links to the guidelines and the operational handbook, which is really providing operational guidance on how to implement the recommendations, as well as the link to the WHO TB knowledge sharing platform, where all the guidelines and all the handbooks, as well as training materials, have been published as well. So just a quick summary of the recommendations that we cover. So we are covering TB screening, looking at the tools for screening for the different age groups, as well as people with HIV. And then, there we go. So, and we also cover TB prevention, looking at BCG, TB preventive treatment in terms of the target groups and the regimens that are recommended, as well as TB infection prevention and control. Then in terms of the diagnosis, the guidelines and the handbook cover the use of rapid diagnostic tests, including Expert Ultra and MTB-RIF on different pediatric specimens, including stool, as well as the use of integrated treatment decisions with evidence-based examples in the operational handbook. And then in terms of treatment, the treatment regimen, 4-month regimen for non-severe TB, that's the topic of my talk today, as well as alternative regimens for TB meningitis, as well as drug-resistant TB. And Kerry will be covering updates to the management of drug-resistant TB in children and adolescents. And then we also have recommendations on models of TB care, which look at decentralization of TB services and family-centered and integrated services. So to start, in terms of treatment, this table provides an overview of the recommended regimens for drug-susceptible TB. So you can see the 4-month regimens, of which we have 2, the one for non-severe TB in children between 3 months and 16 years. And then we also have the HBMZ regimen, which is for pulmonary TB of any severity in adolescents aged 12 years and above. And then, of course, the 6-month regimen is also still recommended for any age, and that excludes severe extrapulmonary TB, for which we have specific regimens. In the case of TB meningitis, we now have an alternative regimen that is shorter and that uses ethionamide instead of ethambutol. And then, of course, the 12-month standard regimen is also still recommended. Just to flag that we have e-courses on the management of TB in children and adolescents. One is targeting healthcare workers at the primary healthcare level, and the other one is more focusing on programmatic considerations, so more for program managers and consultants supporting national programs. So these courses are available on the Open WHO platform, and if you're interested, you would just first need to register on Open WHO before you enroll in the courses. So zooming into the shorter treatment duration in children with non-severe TB, this slide shows the actual recommendations, the actual recommendation that we have. So this recommendation is for children and adolescents between 3 months and 16 years of age with non-severe TB without any suspicion or evidence of multi-drug resistant TB. And it's a strong recommendation for the 4-month regimen. And it's important to realize that this regimen really uses the standard first-line regimens. It's just that the continuation phase is reduced to 2 months. And in the yellow block, you also see the definition of non-severe TB, which is defined as peripheral lymph node TB, intrathoracic lymph node TB without airway obstruction, also uncomplicated TB pleural effusion, or paucibacillary non-cavitary disease confined to less than 1 lobe of the lungs and without a biliary pattern. And children and adolescents who do not meet the criteria for non-severe TB should receive the standard 6-month regimen, or if they have more severe forms of extrapulmonary TB, they should get the recommended regimen for that. And then we recommend the use of ethambutol in the first 2 months of treatment in settings with a high HIV or isoniazid resistance prevalence. So going into a little bit of detail on the SHINE trial that was that provided the evidence for this recommendation. The SHINE trial was an open label treatment shortening non-inferiority trial involving children with non-severe but symptomatic, presumably drug susceptible smear negative TB in Uganda, Zambia, South Africa, and India. And children below the age of 16 years were randomly assigned to 4 months or 16 weeks or 6 months, so 24 weeks, of standard first-line anti-TB treatment with pediatric fixed-dose combinations as recommended by WHO. The primary efficacy outcome was unfavorable status, loss to follow-up, or a composite of treatment failure, loss to follow-up, or death by 72 weeks of follow-up. And that excluded the participants who did not complete 4 months of treatment. So that was the modified intention to treat population. And then a non-inferiority margin of 6 percentage points was used. And the primary safety outcome was an adverse event of grade 3 or higher during treatment and up to 30 days after treatment. So on this slide, you see the randomization approach. And the SHINE trial sites, you can see them on this slide. So in South Africa, Zambia, Uganda, and India, and the main inclusion criteria were age between 0 and 16 years, with a weight of more than 3 kilograms, no known drug resistance, and a clinical decision to treat. These children would be symptomatic but have non-severe TB, and the same definition was used in the trial and of course we took that as the definition in the recommendation as well. These children would be smear negative on respiratory samples. Gene expert positive was allowed, and they should not have been treated for TB in the previous 2 years. And they should have a known HIV status, either positive or negative. Then you can see on this slide the main efficacy outcomes. And for the modified intention to treat analysis, that included all children who were randomized, excluding late screening failures, those who didn't reach week 16, and those who completed treatment but were well but were lost before week 72. And then we also had the per protocol analysis, which was the modified intention to treat population, excluding those who were not adherent to allocated treatment. So here you can see in the forest plot that the risk difference between the 4 months and the 6-month regimen really fell around the 0. So there was no difference in outcomes between the two regimens or the two durations, so to speak. There's also the table with the 34 unfavorable outcomes in the modified intention to treat population. And you can see there wasn't a huge difference between the two. And this was all published in the New England Journal of Medicine. And so this is a summary of the efficacy outcomes by subgroup in the modified intention to treat analysis. And you can see here that overall, in both age groups, the risk difference was very similar, and almost all of these linger around the 0 mark, meaning that there was no significant difference between the two groups. The only difference that you can see here when you look at the HIV status is that for HIV positive children, although the average was clearly to the left, you can see that the confidence intervals was quite wide, and so the certainty for children with HIV was a little bit less pronounced, but still important. So the recommendation was includes also HIV positive children. In terms of safety outcomes, these are some tables that show the results there. You can see that there is also no difference between the two groups in safety outcomes in terms of the number of grade 3 or greater adverse events on treatment after week 16 or at any point in treatment. So these results were really important in terms of informing the recommendation on the implementation of this regimen. So here is after week 16, and then the total number of serious adverse events as well, very similar in both groups. And in terms of deaths as well, no significant difference. And also in terms of the deaths, this table shows the underlying causes that were established by the expert, the trial review committee, clinical review committee. And also just to put that in the context of mortality in the general population, you can see there that there is a substantial background mortality in children under 5. So there was a slightly higher mortality rate compared to the overall mortality in the general population. So that's the evidence that sort of underpins the recommendation that was reviewed by the Guideline Development Group. That meeting was held in 2021. Sorry, I couldn't hear that. Is there a problem?
No, continue, please. I mean, it was just a...
Okay, sorry, thanks. So the Guideline Development Group meeting was held in 2021, and then that guideline was published in 2022. So now looking at some implementation considerations for this, for the implementation of this regimen. Of course, what is very important is the eligibility and how to assess the eligibility for this 4-month regimen. So who are the children who have non-severe TB, who can get 4 months treatment instead of 6 months. So the main considerations are access to chest X-ray and bacteriological testing, and then clinical assessment. So this slide summarizes the sort of implementation guidance on how to assess eligibility. So if you have access to both chest X-ray and bacteriological testing, The eligibility will be based on the chest X-ray features as mentioned, and then also combined with expert MTB-RIF or ultra, that is negative, trace, very low or low. And the child should then also have mild symptoms not requiring hospitalization. And then if in the middle, you'll see the criteria. If you don't have access to chest X-ray, but you do have access to bacteriological testing, again, the criteria would be based on those expert results and the mild symptoms not requiring hospitalization. But especially in lower income countries, there may be limited access to both chest X-ray and bacteriological testing. And in this case, the third scenario really applies to children under 10 who have isolated peripheral lymph node TB, and then again, the mild symptoms that do not require hospitalization. So the child should be relatively well, not very, very ill, and just have isolated peripheral lymph node TB or pulmonary TB, which really presents in a mild way. And in the operational handbook, we also sort of define those mild symptoms, and those would exclude any danger signs or high priority signs, including no asymmetrical and persistent wheezing, no signs of extrapulmonary TB other than peripheral lymph node TB, and also none of the following: severe acute malnutrition, respiratory distress, high fever, means over 39 degrees Celsius, severe pallor, restlessness, irritability, or lethargy. And then danger signs are really defined as per IMCI, so in the Integrated Management of Childhood Illnesses, or the ETAT, the Pediatric Emergency Triage Assessment and Treatment. And then, of course, you will have children who are started on the 4 months regimen without a chest X-ray. Those children would need to be followed up on a regular basis, on a monthly basis. And TB symptoms would then be expected to have resolved within a month of treatment. And then at 4 months, you would expect these children to be well, including a normal nutritional status or similar to before they developed symptoms of TB. And treatment should be continued for 6 months if there's no response after 4 months clinically in terms of demonstrating weight gain and resolution of TB symptoms. And of course, these children should also be evaluated for drug-resistant TB and non-TB related disease, for example, malignancy or HIV-related lung disease, as well as, of course, poor treatment adherence. Now, assuming that in the European region, most children will actually get a chest X-ray at the time that they are diagnosed. So just to give you some more information about assessing severity on chest X-ray, there's a very useful resource that was published by the Union, which is the Diagnostic Chest X-ray Atlas for Pediatric Pulmonary TB, a guide to chest X-ray interpretation to diagnose pediatric TB, which is the 2nd edition. And that also has some guidance on determining whether the TB that you see on the chest X-ray is non-severe or severe. And these images sort of summarize the type of TB, the type of X-ray features that point to non-severe TB and to more severe disease. So on the left, you see the non-severe features. That includes uncomplicated lymph node disease, a primary gone focus without any further complications, and a simple pleural effusion. And then on the right, you have more complicated lymph node disease, especially if there is compression of the airways, as well as combination with parenchymal changes, and also a hyperinflation and collapse. And then a primary gone focus with cavitation would also be more severe disease, and a complicated pleural effusion, which would include effusions that are loculated and or associated with parenchymal disease as well. So just to give you a few more. So again, on the left, non-severe, on the right, severe features. So non-severe would be opacities that take up less than one lobe, as opposed to opacities that involve a whole lobe of the lungs or multiple lobes. And then interstitial pneumonia would be non-severe, but any cavitary disease would really be severe forms, severe TB. Then also in terms of perihilar infiltrates, usually they are non-severe, but if they are associated with other features, they can be classified as severe. And other severe features includes expansile pneumonia, of course, miliary TB, which is really disseminated TB, and TB bronchopneumonia. But just giving you some examples of chest X-rays, and I hope they project in a decent way. Of course, when you see them on the screen, they might be a little bit blurry every now and again. But this is an example of non-severe disease. You can see an enlarged right paratracheal lymph node and a primary gone focus as well. Here's the gone focus. So this is non-severe disease. Another example here, which shows more severe disease with patchy opacities throughout the lungs and cavities in both lungs as well. So this is progressive primary disease, which is classified as severe. Another example here are bilateral enlarged paratracheal and hilar lymph nodes, which is non-severe disease. And here, another example where you have an enlarged right paratracheal lymph node with a shift to the left, and then associated with that narrowing of the left main bronchus. So this is the shift here with the arrow. And then you can see the narrowing here between the little arrows caused by an enlarged hilar lymph node, which are compressing the airway, and that is severe disease. So you always need to look at the airways to see if there's no narrowing. And as soon as there is narrowing, it really points to more severe forms of the disease. Here's another example of bilateral airway narrowing caused by an enlarged subcarinal lymph node. So you see that basically that whole block of lymph node enlargement and associated narrowing of the airways. And then here is an example of an uncomplicated pleural effusion. It is quite large, but it is uncomplicated, and it still classifies as non-severe disease. Whereas this one, it's actually a smaller pleural effusion, but it's loculated, and you can also see underlying lung disease. So this is an example of severe disease. And then in this slide, you also see the AP and the lateral view, which show segmental opacification in the right middle lobe, and with the lateral view, you can see that it is it involves a segment of the lobe and not the whole entire lobe. So this is classified as non-severe disease. And then another example with a segmental opacification of the right lower lobe with peritracheal lymph nodes on the AP and the lateral. And also this is, again, non-severe disease because the opacity is less than 1 full lobe. And on this one, this is not a great picture, it's very pixelated, but you can see here that there's an opacity in the entire right upper lobe. The X-ray is also slightly rotated. And the enlarged lymph nodes may be present, but it's not easy to see because the opacification is so dense, and this would be severe disease, as you can see here. And then, of course, very important classical features here on this X-ray as well, which are the fine millet-sized nodules. They're all of similar size and they're evenly spread throughout the lung fields. And there's no other radiological signs of TB visible on this X-ray. And this is really typical of miliary TB, which is severe disease. Then lastly, this one is quite a young child, a young infant with patchy opacifications widespread throughout both lungs, with areas of breakdown as well, with cavity formation, mainly on the right. And there's also compression of the left main bronchus and likely an enlarged subcarinal lymph node. And this is TB bronchopneumonia in an infant, which is definitely severe disease. Now, to just end, looking at uptake of this regimen. The guidelines came out in 2022. We have requested countries to report on the numbers of children that have started on the 4-month regimen for non-severe TB for the global TB report that will come out at the end of October. I won't give you all the details, but we can see that implementation is still quite limited, with only 2 high-burden countries reporting children started on the regimen in 2023. We do know that a lot of countries are in the process of updating their guidelines and are planning to either first run some pilots and then expand programmatically, or already implement on a wider scale. But on this map, you can see in green countries that are already implementing, and in blue countries that are planning pilots or smaller scale implementation. And then in yellow, countries who are planning or in the process of updating their guidelines. And then we'll start capacity building and implementation. And then in red, as far as we know, countries who are not yet planning to implement. And of course, these data may be a little bit outdated because it's based on reports from countries at the time of the NTB summit last year in 2023, and updated with any available data that we have. Of note, WHO GTB and the special program on training in tropical diseases, TDR, are planning to develop an implementation research package very similar to what was developed for the external validation of the treatment decision algorithms. And that is something that is going to be developed in the next period, and that will hopefully provides useful data on implementation and can help overcoming any barriers that countries may face in the implementation of this regimen. So that was my last slide. So I would like to thank especially the colleagues from WHO GTP, especially Annemieke, Kerry, also Tiziana Mazzini, and our unit head Farai Mavunga, and our director Teresa Kazaeva. And of course also the SHINE trial team for providing the data that was at the basis of this new recommendation. So thank you very much for your attention. Happy to answer any questions.
Спасибо большое, Сабин, за прекрасную презентацию. Конечно, всегда хорошо, когда есть возможность.
Thank you, Sabine, for such an interesting, useful presentation. It's always good to have a shorter treatment regimen to treat children, and we are surprised at such a slow rollout of this treatment regimen at the global level. It will be interesting to look at the outcomes of the trial you have, which will be conducted with the Operation and Implementation Research Package. At that, please let me pass the mic to our next speaker, Kerri Wайни, who will tell us about new shorter treatment regimens for the treatment of drug-resistant TB in children and adolescents. Dear colleagues, I would like to remind you to use our chat to ask questions, as usually we have very little time left at the end. Don't waste the time. If you have any emergent or burning questions, or if you want to clarify anything, please leave your comments in the chat and we will see to all those questions.
Great, thank you very much, Elmira and Askar and the team, and thank you to Sabina for presenting. Elmira, can I just confirm that you can hear me okay? Yes, I can see a nod. Great, perfect. Well, thank you everyone, and really delighted to be here to speak to you and follow on from Sabina's presentation on drug-resistant TB in children and adolescents. And the landscape for the treatment of drug-resistant TB has changed and is changing rapidly, as many of you know. So we'll present the current situation, but also present some updates that will be coming very soon. Now, just to start with, I have a little bit of epidemiology, and the case detection gap for TB in children, generally speaking, is large. So for drug-susceptible TB, we know that about half of the children are detected and about half are missed. However, for drug-resistant TB, we have some modelling estimates that tell us that about 32,000 children develop MDR-TB every year. This is children aged 0 to 14. But the number actually detected and started on treatment is much lower. It's between 4,000 to 6,000 per year. And the majority of those are from India, the Russian Federation, and South Africa. So less than 20% are detected. Now, we've recently convened an individual patient database on drug-resistant TB, which was convened by the Benefit Kids Project. This database consisted of over 24,000 records. Over 80% of that number were adolescents aged 12 to 19 years, and about 90% were bacteriologically confirmed. So this really suggests that young children with drug-resistant TB are not detected, and treatment is seldomly started in the absence of bacteriological confirmation of drug-resistant. So our main gap is case finding. Now, in terms of case finding of children with multi-drug resistant TB, of course, I think you're very well aware that the risk factors for MDR-TB in children and adolescents would be exposure to a person who had confirmed drug-resistant TB, often an adult, quite often a household contact, or exposure to a person who has failed TB treatment or died from TB. And therefore, contact investigation really remains a critical intervention to identify children and adolescents who have been exposed to drug-resistant TB and who may need treatment or indeed who may need prevention. Now, some of the other risk factors, of course, might be non-response to first-line TB treatment in a child or previous TB treatment. And children who have a decision to start treatment based on the treatment decision algorithms that WHO is recommending should be assessed for the risk of drug-resistant TB. And in fact, that is a step that is included in the treatment decision algorithms. So therefore, healthcare workers should have a high index of suspicion for drug-resistant TB, given the conditions that we've described above. It's critical to try and obtain a specimen for bacteriological testing. It's not always possible, but it's critical to try and do that. And if this testing is negative or it can't be done, a clinical diagnosis can be made, and the resistance pattern of the child or adolescent, the person that they're exposed to, would likely inform treatment. Now, this slide Sabine has already showed. It just shows the new recommendations that came out of the guidelines in 2022. There were a range of recommendations, 8 new recommendations actually, that were issued on the management of TB in children and adolescents in 2022. And I'm going to focus on the MDR TB treatment recommendations, and then I'll talk about some of the new recommendations that will be coming out in Q1 of 2025, and which have been signalled in a rapid communication that WHO issued in June. So in 2022, as I mentioned, WHO issued new guidelines on the management of TB in children and adolescents. And as Sabine mentioned, this followed a guideline development group meeting that was held in 2020. So with respect to the treatment of drug-resistant TB in particular, these were 2 new recommendations that were made at the time. And the first one that you can see at the top of the screen is that in children with MDR or rifampicin-resistant TB aged below 6, an all-oral treatment regimen containing bedaquiline may be used. And then the second new recommendation was that in children with MDR TB aged below 3, delaminid may be used as part of longer regimens. Now, these recommendations applied to and complement the current recommendations that were available at the time. And at the time, there were age restrictions on the use of both drugs. So bedaquiline was not recommended for children below 6. Delaminid was not recommended for children below 3. So this effectively removed the age limits for both medicines and made it possible to build all oral regimens for children of all ages to treat drug-resistant TB. Now, shortly after we released the guidelines in 2022 and aligned to those 2 new recommendations, WHO also published 2 information notes that you can see here on the screen, one on bedaquiline in green and one on delaminid in blue. And these information notes really provide practical guidance on the administration of bedaquiline and delaminid in children and adolescents in the context of MDR TB treatment, of course, and in line with the WHO recommendations, using the formulations that are available for children. And I'll talk a little bit more about that later. So in terms of where we are at for treatment of drug-resistant TB in children and the use of bedaquiline and delaminid, so this is the current landscape for the treatment of drug-resistant TB in children, but this is about to change. So you can see in the left-hand column, we have the 9-month all oral regimens. There is an ethionamide variation and a linezolid variation. These can be used for all ages and in fluoroquinolone susceptible only, so not for pre-XDR and not for XDR. It's not recommended that they are used for children and adolescents with extensive pulmonary TB. They can be used for some forms of extrapulmonary TB, but not the more severe forms. And they can be used in children where a clinical diagnosis is made of drug-resistant TB. Now, these regimens are 9 months in duration, extendable to 11 months if there is sputum smear positivity at month 4. But of course, that may not be possible to get that specimen in children. Then in the middle column, we have the BPAL-M regimen, which I think you're very familiar with in this region. And this, of course, is the preferred regimen in those aged 14 years and above. So it's not eligible for children aged under 14. can be used for fluoroquinolone susceptible and fluoroquinolone resistant MDR-TB, not for XDR-TB, can be used in extensive pulmonary TB and the non-severe forms of extrapulmonary TB. It's not recommended to be used if a clinical diagnosis is made, and of course the duration is 6 months. And then, of course, in the far right column, we have the individualized regimens, which are 12 to 18 months, even longer for adults. And these can be used across all of those indications on the screen. And additional factors that might determine the choice of regimen would include drug intolerance or adverse events, the treatment history, of course, including of the source case, previous exposure to the drugs that are used in the regimen and the likelihood of their effectiveness, patient or family preference, access to child-friendly formulations in the country, and potentially even cost. So this is the situation as it is now in 2022. And just to show this, So as I mentioned, this is the situation we have. We have BPAL-M, but not recommended for those aged under 14 or who are pregnant or who are breastfeeding. But the majority of people aged above 14 should actually be receiving BPAL-M or BPAL. Then, as I mentioned on the previous slide, the next option is the 9 to 11 month regimen, either the ethionamide variation or the linezolid variation. It does include 7 drugs in the intensive phase, so that may or may not be acceptable for all situations, even when dispersible formulations are used. And then finally, we have the longer individualized regimens. They are 18 to 20 months for adults in the guidelines. They can be shorter for children with non-severe TB, but we don't have good evidence on how short is short for the longer individualized regimens. Now, thinking about the future, WHO issued a rapid communication on the treatment of drug-resistant TB for all ages in June 2024, and the link to that rapid communication is just here at the bottom of the screen. And this was following a guideline development group meeting that was held in June, and I think Elmira is very familiar with that guideline development group meeting, and Askar and other colleagues as well. So there was some new evidence assessed at that guideline development group meeting, and one of the trial evidence that was assessed was the BEAT-TB trial from South Africa. And this included 6 months of bedaquiline, linezolid, delamanid, levofloxacin, and clofazimine versus the standard of care. And the standard of care was a 9-month regimen. Now, based on the assessment of this evidence at the guideline development group meeting in June, WHO is now recommending the use of a 6-month treatment regimen composed of bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine in people with MDR-TB with or without fluoroquinolone resistance. If there is fluoroquinolone resistance, clofazimine is used. If there is not fluoroquinolone resistance, then clofaz is used. Now, this applies to children and adolescents, people living with HIV, pregnant and breastfeeding women. So where we had a gap for those aged under 14 for the BPAL-M regimen, this regimen actually fills that gap for children. It can be used in those with extrapulmonary TB, except TB meningitis, osteoarticular TB, or disseminated forms of TB with multi-organ involvement. And it can be used with a clinical diagnosis. So if children and adolescents don't have bacteriological confirmation or DST, but they do have a high likelihood of having MDR-TB, then this regimen can be used. Now, another piece of evidence that was assessed was from the END-TB trial. This was a trial that was conducted in 7 countries and assessed 5 regimens that you can see in the right-hand panel on the screen versus the standard of care. The standard of care was mostly the 18-month regimen, and this evidence was assessed by the Guideline Development Group in June 2024. After assessing this evidence, the new recommendation that WHO is issuing is that they suggest using the bedaquiline-based 9-month all-oral regimens over the currently recommended longer regimens in patients with MDR-TB and in whom resistance to fluoroquinolones has been excluded. So this is for people with fluoroquinolone susceptible TB. So you can see in the figure on the right of this slide, there were 5 regimens tested in the NTB trial. The 3 that have been recommended are bedaquiline, linezolid, moxifloxacin, and pyrazinamide. Bedaquiline, linezolid, levofloxacin, clofazimine, and pyrazinamide, and bedaquiline, linezolid, levofloxacin, clofazimine, and pyrazinamide. And there is a suggested order in terms of the preference of which regimen should be used. So I'll just use the shorter names. So BLMZ is suggested over the clofazimine-containing regimen, and the clofazimine-containing regimen is recommended over the levofloxacin and linezolid-containing regimen with delaminid. Now, this is a conditional recommendation, and it does apply again to children, adolescents, pregnant and breastfeeding women, and people living with HIV. Similarly to the BEAT TB trial regimen, it can be used in people with extrapulmonary TB, except for the more severe forms, so CNS or TB meningitis, osteoarticular TB, or disseminated forms of TB with multi-organ involvement. And similar to the BEAT TB regimen, it can also be used in children and adolescents without bacteriological confirmation. But of course, you have a high likelihood of MDR-TB based on the clinical signs and symptoms in combination with the history of contact with someone with confirmed MDR-TB. So very exciting that we now have these 2 new recommendations on the horizon, and WHO will be issuing new guidance and an operational handbook in Q1 of 2025. Oh, it's not moving, the slide's not moving, sorry, just... Slide doesn't want to, oh, there we go. Now, both the BEAT TB trial and NTB were extrapolated for the pediatric populations. The GDG used this pediatric extrapolation framework because there were data available on PK and safety. So in fact, both of these regimens now, as I mentioned, do apply to children and adolescents as well. And this was this is an FDA framework that is accepted for extrapolating when there is not specific evidence on the pediatric population, but when you have PK and safety data for that. Now, so if we look at an updated mapping of drug-resistant TB regimens now, this is what we have with the new recommendations. So we have 2 6-month regimens, or 3 really. We have BPAL-M, which is only for 14 years and above. And we have the new BEAT-TB or BDLLC regimen, also a 6-month regimen. So we have those 2 6-month regimens on the left-hand side of the slide. And then we also have 9 to 12-month regimens. We have the 2 regimens that are 9 to 11 months, one with ethionamide and one with linezolid. And we have the 3 newly recommended 9 to 12-month regimens from the NTB trial. And of course, they should be used over the longer individualized regimens. And I think it would be expected going forward that the longer individualized regimens are used less and less, and would only be used for people who indeed have an extensive drug resistance profile. Now, if we think about what the options are specifically for children and adolescents, and they're highlighted here in the 2 orange boxes. So really the new recommendations that are coming out and that have been issued by WHO in June, they really change the landscape for the treatment of drug-resistant TB in children and adolescents. It means that children aged under 14 can receive the 6-month regimen, the so-called BEAT TB regimen. And then if they're not eligible for that, they can have the 9 to 12-month NTB regimens if they are fluoroquinolone susceptible, and they use a lot fewer medicines than the 9 to 11-month regimens, which use 7 medicines in the intensive phase. Now, this is a very sort of busy slide, but it's just meant to sort of summarize some of the considerations for choosing a pediatric regimen to treat children with drug-resistant TB. And of course, when WHO publishes the operational handbook on the management of drug-resistant TB, there will be much more detail on all of these factors to help clinicians decide which regimen is most appropriate given all of these factors here on the screen. So as I explained in the previous slide, we do have some age cutoffs for the 6-month regimen, so that will be a key consideration. We do have some considerations about bacteriological confirmation, what is the drug susceptibility pattern, either of the child or the source case, or in some cases a clinical diagnosis may be made. There are other considerations such as monitoring ability and the ability to carry out ECGs and full blood counts, etc. There's also considerations around the severity of disease, the level of care that the treatment is being offered in, and also the pill burden and the formulations available in the country. Now, of course, one of the important programmatic considerations is the use of child-friendly formulations. These are now available for all of the second-line TB medicines that are available to treat drug-resistant TB, and these are available through the Global Drug Facility, and you can see their catalogue, the image of their catalogue on the slide at the Stop TB Partnership. They also have an information note on child-friendly formulations for drug-resistant TB, so they provide some guidance. And we generally request that the child-friendly formulations are used whenever possible and included in funding requests. And I think it's just worth noting that the GDF does have the new formulations of bedaquiline, the 20 milligram tablet, which can be dispersed, the delaminid 25 milligram dispersible tablet, and the linezolid 150 milligram dispersible tablet. So they're all available through the Stop TB Partnership's Global Drug Facility. And then just finally to conclude, obviously the dosing guidance, the availability of the child-friendly formulations is important, but how to dose those medicines is also important. So there is dosing guidance in the operational handbook on the management of drug-resistant TB that currently exists. We have dosing guidance right down to 3 kilograms, so that is birth. There is an age and weight-based approach for both bedaquiline and delaminid, so I think that's worth noting. And we have provided information on dosing using the child-friendly formulations in this dosing guidance, but also in some instances the adult formulations. And of course, the final approach to dosing does depend on what you have available in your country. There is also a dosing calculator in the knowledge sharing platform app. And yeah, we've tested that a few times, and it's quite a useful little app to provide all of the dosing guidance. You put in the age of the child and the weight, and it gives you the dose of the medicine that you would need. And I'll just conclude there. I'd just like to thank my colleagues, including Sabine and Anamika, who are on this call, Tiziana, our director, Teresa Kasayeva, and our unit head, Faraima Vunga, and all of the colleagues from the WHO Global TB Program, including the treatment team. We're happy to be emailed with questions at any time. And just to say again that the new guidelines and operational handbook on the management of drug-resistant TB will be issued by WHO in Q1 of 2025. So that's when you will have all of the information on these new regimens. And I'll finish there. Thank you very much.
Большое спасибо, Керри, за прекрасную презентацию.
Thank you very much, Kerry, for an excellent presentation. It is good to know that finally children with pre-XDR-TB and XDR-TB can receive 6-month treatment regimens. It was a big question on how to treat children with longer treatment regimens while we have shorter treatment regimens available. And now I would like to give the floor to the next speaker, Dr. Николь Салазар-Остин from Johns Hopkins School of Medicine, who will share some new data on management of newborns of mothers with TB disease. Nicole, the floor is yours.
Hello, everyone. I'm super happy to talk today about the management of newborns of mothers with TB disease. So I'm going to talk a little bit at the beginning about the burden of TB disease in pregnancy, the consequences to the infant, thinking about perinatal versus congenital TB, and then finally the management of these infants with regard to evaluation, treatment, isolation, and breastfeeding. So the TB burden in pregnancy is probably high, but it's actually unknown. So in the last global TB report released from WHO last year, we know that in 2022, there were about 10.5 million people with TB disease, including 6 million males, 3.5 million females, and 1.2 million children. From modeling estimates, we believe of those 3.4 million, there were about 216,000 pregnant women. However, data on TB and pregnancy is not commonly collected by TB programs, and the true burden of disease is actually unknown. Oops. So here we do believe that those numbers are accurate. We know that, or those modeling estimates are probably fairly accurate. The majority of women who develop TB disease do so in their childbearing years. So reasonable to think that a fair number are indeed pregnant. We also know that the risk of TB disease in pregnancy and in the postpartum period is a little bit higher. I think the strongest argument for this comes from Zenner and colleagues, who published a paper in the European setting showing that the TB incidence in the postpartum period was 2 times higher than in the non-pregnant and non-postpartum period. And then it's also good to point out just that other children in the household are therefore also at risk. And so it's not just the mom and the baby, but if mom has other children at home, and particularly young children, they are also at risk. So in pregnant people living with HIV, there have been a number of studies looking at the sensitivity of the 4-symptom WHO TB symptom screen, which has a relatively poor sensitivity among pregnant women living with HIV, with a pooled sensitivity of just 22% compared to 79% in people living with HIV. And so additional screening methods may be needed to identify pregnant women living with TB and HIV, but perhaps also just pregnant women living with TB, as many of these symptoms are often misattributed to pregnancy and not TB disease. So we know that there's increased identification of TB in pregnant women living with HIV. Colleagues in South Africa conducted a cluster randomized trial where they looked at universal screening of all pregnant women, irrespective of symptoms, and compared that to a more standard symptom-based testing approach. Initially, they used expert only. They didn't find a lot of TB. They expanded from expert to midget culture and ultimately found a 10-fold increase in the detection of TB in the universal versus symptom-based screening arms. Expert only detected about 1/3 of the rate of TB compared to midget, indicating perhaps lower bacillary loads and some recent reactivation and subclinical disease. They also found half the infant and maternal deaths, though this was not statistically significant. So consequences of maternal TB, there are consequences for both mom and baby. There is an increased rate of adverse maternal and pregnancy outcomes, including a 4-fold increased maternal mortality, a 10-fold increase in hospitalization, and a 9-fold increase in miscarriage. Similarly, there are increased adverse infant outcomes with a 4-fold increased risk of perinatal death, a 2-fold increased risk of low birth weight and preterm birth, and a 5-fold increase in birth asphyxia. So as I was saying before, we believe that much of the TB disease that's happening in pregnancy may be sort of recently reactivated, could be subclinical, may have lower bacillary loads. And in a study we conducted in South Africa amongst pregnant women living with HIV, and pregnant women with HIV as sort of controls, we found that a fair number, 7 out of about 150 women who were enrolled as controls without TB disease, had a culture positive at enrollment for TB disease. And we looked at the infant outcomes associated with this, quote, subclinical disease, and found that there was still a higher risk of adverse infant outcomes for both infant TB and hospitalization than with mothers who were living with HIV alone. I think there hasn't been a lot of historically a lot of press and interest in maternal TB, but I think that's beginning to change. The WHO integrated maternal TB into their child TB roadmap last year and identified a number of key actions that are really needed. A better understanding of the burden of disease that we talked about, ensuring pregnant and postpartum women and their infants are protected through research and not from research, and really including them in these studies, and then also conducting rigorous operational research and surveillance studies to understand these outcomes better. So I wanted to talk a little bit about perinatal tuberculosis. So traditionally, we talk about congenital TB, but I think there's a spectrum of disease in the neonates that's worth pointing out and worth thinking about. So congenital TB is in utero infection with Mycobacterium tuberculosis, and this is fairly rare. Maternal TB bacillemia with either primary or disseminated TB results in dissemination of the infection to the placenta, to the endometrium, or the genital tract. With transplacental transmission, this is the primary focus for the infant is in the liver because of how the sort of fetal circulation works. And then if the mom has TB endometritis or a placental infection, the primary focus would be in the lung or in the GI tract as they sort of aspirate or ingest the TB. I think also worth noting that postnatal TB is important, and that this is more common than congenital TB. And here, this is sort of your more standard maternal infectious pulmonary TB disease, untreated cavitary disease, et cetera, with airborne transmission, where the primary focus is then in the lung. There are sort of strict diagnostic criteria for congenital tuberculosis, which are honestly difficult to prove in any setting, but particularly in low resource settings. So the Cantwell criteria were published in the New England Journal of Medicine in 1994, and here it's presence of proven TB disease in the infant with at least one of the following. So lesions within the first week of life, the primary hepatic complex or caseating hepatic granuloma, as I discussed, TB infection in the placenta or maternal genital tract, and then exclusion of the possibility of postnatal transmission by investigation of contacts, including hospital staff, which is always a difficult one to accomplish. So congenital TB signs and symptoms, I think they're generally non-specific. You tend to have a very ill neonate who's febrile, tachypnic, lethargic. There may be organomegaly and pulmonary infiltrates. Typically, the median time to presentation is 2 to 3 weeks, but it can be up to 3 to 4 months. And so the data below are sort of combined from 75 cases in 38 case reports or case series. And the most common symptoms tend to be respiratory distress, including tachypnea, hepatosplenomegaly, fever, which is often low grade, and prematurity or low birth weight. Frequently, these infants will also be coughing. They'll have poor feeding and failure to thrive, And sometimes they'll also have abdominal distension, which is really reflective of associated ascites. Infrequently, they can present with irritability, peripheral lymphadenopathy, a sepsis-type syndrome. They can have skin lesions. They can have meningitis. They can have obstructive jaundice. They can have wheeze. They can have apnea. They can have nerve palsies and shock. So getting into the management of these infants. So Nadia Hassan and Ben Marai collected a group of us to think through what a consensus guideline may look like. They started with a systematic review, looking at a couple of different online libraries and papers published through the end of 2022. They found 521 papers, 3 of which met inclusion criteria. And unfortunately, no evidence-based conclusions could come from this because of the narrow scope, variable aims, the descriptive nature of what is often presented, inconsistent data collection, high attrition rates. And so they decided to develop this sort of consensus guideline, and they reviewed 16 international guidelines. They convened an international panel of experts from both high and low burden settings, high and low resource settings. And then they developed guidance for mothers who were potentially infectious and non-infectious at delivery. And the point of all of this was really to create more consistent clinical management, to support the collection of better data, and then also to encourage the development of additional studies to improve the evidence-based care. And so there are sort of 2 main sort of diagrams that were published in this paper. The first was around the management of infants born to mothers with potentially infectious TB at delivery. And here that was defined as a mother who had completed less than 2 months of TB treatment prior to delivery, or who had no clinical improvement, or who did not have sputum conversion on treatment of any duration. And I think we recognize here that 2 months is a little bit conservative. It considers maternal resistance, the fact that there may be other ill or infectious household members, and that culture and smear conversion may not be documented until 2 months in many national programs. These infants then get evaluated, and we'll talk about that in a moment, and it does consider what is locally feasible. If the child is determined to not have TB disease, they would receive TB preventive treatment and also get assessed every 2 weeks for the first 3 months of life. And at any point their clinical concern redeveloped, they would again be evaluated. They would continue with this until 3 months of life, when they would be offered a TST or an IGRA. If either of those were positive, they would complete their TPT. And if it were negative, they would stop TPT and receive BCG. And during the second 3-month period, they would ideally be assessed on a monthly basis. If they did have TB disease, either presumptive or confirmed, we would treat for TB disease, similar to what Sabina has already presented with a typical HRZE regimen for drug-susceptible TB, and then additional time for TB meningitis or drug-resistant TB. I think it's important here to think through 2 things. One, sometimes the infant with congenital or perinatal TB is the first diagnosis in a household. And so maternal TB really may not be diagnosed at the time of infant presentation. And so there needs to be a high suspicion always in sick infants. And then I think the other thing that's important to remember are the risk factors for congenital TB, which is maternal disseminated TB, either miliary TB or TB meningitis, tuberculous pleural effusion, which is suggestive of a recent primary infection, and then also if there's any identified pelvic, genital, or placental TB, though in my experience, that has often been diagnosed after the infant is diagnosed with TB. The comprehensive clinical assessment that appears in this consensus guideline is sort of twofold. So routine for all children, when available, we recommend a chest X-ray and an abdominal ultrasound. We recognize that abdominal ultrasound is not available in all settings. If it's potentially available, we felt that it was particularly important when the mom is at high risk for transplacental transmission, as I just reviewed. And then if the child has any signs or symptoms that are concerning for congenital or perinatal TB, we would recommend, again, an abdominal ultrasound. If there was IUGR, hepatomegaly, and or ascites, respiratory specimens for culture and or NAT, lumbar puncture for cell counts, chemistries, culture, and an expert or other approved molecular testing, fundoscopy for the mom if possible, and then if there are signs and symptoms of CNS disease, brain imaging is recommended. MRI is preferred over CT, which is preferred over head ultrasound, but we also recognize that there is limited availability of some or all of these testings in given settings. So what do we do for the management of an infant born to mother with non-infectious TB at delivery? So this is defined as a mom who's completed at least 2 months and has clinical improvement and sputum conversion. So here it's the same comprehensive assessment of the infant. And if there's not TB disease, but there's still high risk of exposure within and beyond the household, we consider BCG at birth. We assess at 1 and 3 months. If there's clinical concern, they get reassessed. And at 3 months, they receive a TST or an IGRA. And if the IGRA is negative or the TST is negative, we would consider BCG. And if the IGRA or TST were positive, we would provide TPT. And then, of course, if TB disease at any point along the way, presumptive or confirmed, is identified, we would treat accordingly. The group also noted that in low burden settings, there may be a way to simplify some of this. And here, if there was not TB disease, if BCG is part of the guideline, would be given at birth. Infants would still be assessed at 1 and 3 months, but there would be discharge at 3 months if there was no clinical concern. So maternal TB and breastfeeding, I think pediatricians well know that, and in the United States, we say breast is best, but there's a lot of really important health outcomes that are, and positive health outcomes that are associated with breastfeeding. And so we really feel that every effort should be made to facilitate breastfeeding and to minimize mother-infant isolation, recognizing that transmission is low once the mother is on treatment and the infant is on TPT. We sometimes use surgical masks if mom is considered potentially infectious until treatment is initiated. But once treatment, and particularly the infant TPT, is initiated, I no longer recommend the sort of surgical mask. Minimal data sort of exist on TB drugs and breast milk. We're working on developing additional data to support this. In general, the RHZE drug-sensitive TB regimen, we believe, or the data that exists show low levels in breast milk, though we admit that there are no direct measures in infants. And there are really no known safety concerns and a lot of experience with this globally. So breastfeeding with RHZE is generally recommended. There is less experience and fewer data with second-line medications. We do know drugs like bedaquiline have quite high breast milk concentrations in animals and also in humans. And in the one infant who's had exposures measured while breastfeeding and mom was on bedaquiline, they did have therapeutic exposures. I think much of this at the moment, in the absence of data, is really shared decision making between the clinician and the parent. But we recognize that is quite challenging for both the clinician and for the mom who's making this decision. And so WHO is leading a consensus process to really encourage the optimal and early inclusion of both pregnant and lactating women in TB drug and vaccine research. So we hope in the coming years to have additional data so that people can make more informed decisions. I also just want to spend a moment talking a little bit about maternal TB in adolescents. Adolescents are at high risk of progression for TB infection to TB disease. Pregnancy in adolescents is also not uncommon. Pregnant adolescents may also be more likely to experience obstetric and neonatal complications. And so there's a high risk, and there's also a high risk of poor adherence resulting in treatment failure, relapse, resistance, and resulting transmission to their infants. So it's just a special time with a lot of complications that can really make the outcomes for the infant worse. And so close monitoring, a lot of good counseling is really key and important in this population. And so take-home messages: perinatal TB is relatively common, though true congenital TB is rare. It can be acute and atypical. Infants born to moms with TB can be exposed by other household members. So even if mom is well treated, please have a high index of suspicion. A high index of suspicion is probably also needed because moms are not always diagnosed prior to delivery. Optimal TB screening for the mom, and particularly if that mom is living with HIV, is unknown. There are new expert opinion consensus treatment guidelines that are available, and really we try to facilitate breastfeeding as much as possible, recognizing that transmission is really quite low once the mom is on treatment and the infant is on prophylaxis. And I'll end there. Thank you so much.
Thank you so much, Nicole, for such a great presentation and for sharing such a freshly baked systematic review. Thank you so much. I already shared the manuscript in the chat box. Meanwhile, I suggest our auditory to write their question into the chat box. The majority of the questions were already addressed, but I don't see any new questions. And may I have one question? Just taking an opportunity. Could you kindly elaborate how you, as a group, decided on this threshold of 2 months of mother on treatment in order to decide whether she is potentially infectious for her child or not? Because, you know, there's modeling studies that shows that even several days of effective treatment is enough for stopping this transmission. So just curious.
Yeah, I think we were conservative there. I think it could also be adapted to individual settings. I think it was hard to create one time point for all settings. And we recognize that at times, things like smear conversion are often in some settings not done until the end of initiation phase. And so you wouldn't know what the treatment response was. Also recognizing that at times the degree of resistance is not always known immediately because you're waiting for culture results to come back. And so you may think that you're on good treatment, but you may not be once those results come back. And so it was particularly conservative. I think if there's, that mom has drug susceptible TB, you have, an expert to confirm that. There's really good response to treatment. If in your setting, and we would do this, for instance, in our setting in the United States, conduct sort of smears earlier than the 2-month period. There's really a lot of evidence, and we have new guidelines in the United States to sort of shorten that degree of isolation to a fairly short period of time after initiating treatment. So I think that's fair, but I think it's very dependent on what information is available in your setting. what the likelihood of drug susceptible versus drug resistant TB is in either that setting or in that person based on exposures, and can get a little bit complex. So we felt that the 2-month period was important to fit all possible scenarios, but I do think with clinical judgment that could be shortened.
Thank you so much. That's very important notice to consider, especially for the European region where the express tests are available and XDR test is also available. So we may be pretty sure far in advance of 2 months that the mother is on the effective treatment. Thank you so much. I don't see any other questions in the chat so far. And I would like to thank so much, Nicole, you, Kerry, you, and Sabine, yours. Thank you so much for brilliant presentation. You always bring some fresh, new information and share it with us. Thank you so much. I'm very grateful, and from our auditory. And I would like to give a word to Askar for closure of our webinar.
Большое спасибо, уважаемые спикеры, уважаемые гости нашего сегодняшнего
Thank you very much, dear
вебинара.
speakers, dear guests of our today's webinar.
Могу только подытожить и
I can only summarize and join all the words of thanks to our presenters on behalf of all the audience members for bringing to light this important topic. We will try to continue informing you. We will do it regularly. It's perhaps the most topical issues, and we will try to cover other important aspects of TB treatment. And we will be very glad to welcome you at all our next webinars. Therefore, stay in touch. Thanks once again. I wish you all good health. Thank you, Askar, and see you later. All the best. Thank you. Goodbye.
Thank you.